Hello, I'm Asyah Shareef, a final year medical student from Arabian Gulf University, and my topic is about Myasthenia Gravis. So, Myasthenia Gravis is an autoimmune disease of neuromuscular junction. The neuromuscular junction contain the ending of neuron that contain neurotransmitter traveling to the muscle, to skeletal muscle, which contain receptor for the acetylcholine. So in Myasthenia gravis, what happened that the acetylcholine cannot bind to the acetylcholine receptor at the skeletal muscle because the body produce autoantibody that falsely attack the acetylcholine receptor at the skeletal muscle. That's why the patient will show muscular weakness that worsen with activity and improve with rest. So myasthenia gravis is most common neuromuscular junction disorder, especially in women's, which more frequently affected than males in a ratio of 3 to 2. It shows bimodal distribution of age of onset, where females get the disease earlier in 20s to 40 years, and males get it at later age, 40 and 70 years. Myasthenia gravis associated with other autoimmune disease, including Hashimoto's thyroiditis, rheumatoid arthritis, sarcoidosis, and systemic lupus erythematosus. One of the most important associated condition with myasthenia gravis is thymoma. Thymoma is the most common primary tumor of the anterior mediastinum, and studies showed that 10 to 50% of patients with myasthenia gravis has thymoma or even thymic hyperplasia in 65% of patients. So the thymus most of the time have participate in myasthenia gravis, either thymoma or thymic hyperplasia. Also, there are some studies that prove gravis versus host reaction after allogenic stem cells, especially in children, can be related to myasthenia gravis. The gravis versus host reaction is simply when the donor cells attack the recipient cells. So in this case, especially in children, it can be related to myasthenia gravis. We can myasthenia gravis into ocular and generalized. The ocular myasthenia gravis is the most common initial symptoms when the patient present with. It mostly affects the extraocular muscle as well as the eyelid muscles. So the patient present with ptosis, diplopia, blurred vision, and so on. Most of the time, ocular symptoms can progress to generalized muscular weakness, where all skeletal muscle may be involved, starting with the eye muscles, the face muscles, and the limb muscles, and in advanced cases, respiratory muscles. Mm-hmm. So the clinical features of myasthenia gravis, the patient most initially present with eye muscle symptoms, such as ptosis, diplopia, blurred vision. Patients also have special characteristics such as nasal quality of speech, facial weakness manifest as snarling appearance when they smile. The skeletal muscle weakness usually have diurnal variation, where the symptoms get worse at the end of the day, because with rest the symptoms improve, and with movement the symptoms worsen. That's why at the end of the day they feel tired and fatigued, and when they take rest, sleep, they return their energy. Sensation and reflexes are mostly preserved. And in generalized myasthenia gravis, as I said, it can involve any skeletal muscle, starting from the eyes, diplopia, blurred vision, and ptosis, and the bulbar muscles, where the patient have dysarthria, dysphagia, difficulty in chewing, and dyspnea. Proximal muscle usually are asymmetrical, where it can affect the arm more than the legs. and it's usually affect the proximal muscle more than the distal muscles. And in advanced cases, it can affect respiratory muscle, causing dyspnea and respiratory failure. And now I will show a video that patient shows some symptoms of myasthenia gravis.
Slightly compromised. Okay, over to you, Lara.
Okay, so first of all, my eyes, I can't screen.
Slightly compromised. Okay, over to you, Lara.
Okay, so first of all, my eyes, I can't screen them up tightly or close them, particularly at night. So, for example, I was really trying my hardest to screen them up, but they're very easy to open. Just by like washing my face, things like that, I can get water in my eyes quite easily. Secondly, it's my cheek muscles around here. I find it quite hard to do facial expressions because they just don't move around here. Then it's my tongue, which affects my pronunciation, so it can be difficult to talk. This in turn affects my swallowing, so liquid goes up my nose, and it's quite hard to swallow. Then obviously I get the neck weakness around here, and it can affect my
Breathing. Okay, so as you can see, as Lara starts to talk, it becomes far more difficult. This is about as bad as her symptoms have got. With a few moments recovery, she's usually able to start talking again, but especially if she relaxes and she's a bit uptight, so it probably won't come back as quickly. But if you try and describe your swallowing part again now, see if that you can say.
So my swallowing gets quite weak, and I find it difficult because liquid goes up my nose. So it's words like with an N, like nose, and
Right, and breathing can be affected. Right, stop again. Right, Lara has just begun.
So this video showed most of the symptoms. So we can notice the nasal quality of speech, the snarling face, and the dysarthria, difficulty in talking. And she described her eye symptoms, facial symptoms, and difficulty in chewing, dysphagia, and difficulty in breathing. So now we have some simple examination that it's clinical based. It mostly shows the ocular findings. We have the symptom test, the IcePack test, rest test, and Gorelick test. I will explain them in the next slide with a video that showed each test, how can it performed, and the findings. So first test is symptom test. Is simply asking the patient to look upward. So when the patient look upward, we can appreciate the dropping of the eyelid. So the left eye shows dropping of the eyelid. And the second test is the caloric test. When we passively open one eye, the second eye shows dropping of the eyelid. And the IcePack test, when we put IcePack on the affected eye, after that we can see that the function of the skeletal muscle return back. So the ptosis disappeared. And the rest test, when we ask the patient to take rest, they will regain their function. The muscles will regain their function. And now regarding the investigations and diagnosis, the best test, the test of choice is acetylcholine receptor antibody. Most of the patients are positive. Only 20% of patients have seronegative test. So in this case, we can use the electromyography, the EMG, that will show decremental responses to the repetitive stimulation of motor nerves as the muscles get fatigued with repetitive stimulation. And for all the patients, we must do thoracic CT scan to rule out thymoma, which present in around 50% of patients. Also, there is old test that is no longer done, is the hydrophonium test or tensilin test, where we inject the patient with rapid-acting short-duration acetylcholine esterase inhibitor, which inhibits the enzyme acetylcholine esterase that break up the acetylcholine. So more acetylcholine in the synapse that show marked improvement of the symptoms of the patient. Regarding the management, we can give the patient acetylcholine esterase inhibitor, pyridostigmine. It's help symptomatic relief only by increasing the concentration of the acetylcholine in the synapse. So that's why the skeletal muscle can function longer. Thymectomy, it's provide both symptomatic and complete remission of many patients. We can done thymectomy for all the patients with thymoma or without thymoma, as around 75% of patients have thymus hyperplasia or any abnormal thymus histology. So most of the patient will have benefit from this thymectomy, even if the CT scan didn't show any thymoma. And in case that the pyridostigmine cannot inadequately control the symptoms or cannot be tolerated, we can try the immunosuppressive drugs such as glucocorticoid or azathioprine to reduce the inflammation in the neuromuscular junction. And myasthenic crisis is an emergency case where there is acute exacerbation of myasthenic symptoms that can reach the diaphragm and intercostal muscle, lead to fatigue and respiratory failure. It can affect around 15 to 20% of patients in the first 3 years of the disease onset. It has some triggers or precipitating factors. Most common precipitating factor is infection. Surgery, anesthesia, pregnancy also can trigger the crisis, as well as medication, especially antibiotic, aminoglycoside, fluoroquinolone, and in addition to beta blockers and hydroxychloroquine. So we can manage the myasthenic crisis with intubation if there is a risk of respiratory failure. Otherwise, we can give something to reduce the inflammation, such as high-dose prednisone, or IVIG or plasma exchange to clear the body from the autoantibodies. And regarding the differential diagnosis, one of the top differential diagnoses that we should rule out is Lambert-Eaton myasthenic syndrome, LEMS. So it's a rare neuromuscular junction disorder characterized by proximal muscle weakness in addition to autonomic dysfunction. And it's usually a paraneoplastic syndrome. It's associated in 2/3 of patients with LEMS with small cell lung carcinoma. So they found that the patient with LEMS, around 2/3 of them have small cell lung carcinoma. That's why it's considered as paraneoplastic syndrome. So what happened in LEMS that there are autoantibody attacking voltage-gated calcium channels. So those voltage-gated calcium channel help the calcium to enter inside the neuron and facilitate an infusion of the vesicles that contain acetylcholine. So if antibody attack the voltage-gated calcium channel, no fusion of vesicles containing acetylcholine and no acetylcholine and muscle weakness. So this is a simple table that compare between the myasthenia gravis and LEMS. So in myasthenia gravis, the most associated disease is thymoma, whereas in LEMS, we can find it as a part of paraneoplastic syndrome. It's associated with small lung cancer. In myasthenia gravis, the initial symptoms are extraocular muscle and the eye ocular symptoms. In addition, that the muscle activity worsen with exercise and throughout the day. Whereas in LEMS, the weakness is mostly in the proximal muscles and it's improved with exercise and throughout the day. Reflexes are normal in myasthenia gravis, but in LEMS, it could be reduced or absent. The EMG, the repetitive nerve stimulation, show decreased response in myasthenia gravis, whereas in LEMS, it show increased response. And the autonomic dysfunction, it's associated only with LEMS. And the responses to cholinesterase inhibitor, it's with myasthenia gravis, but it have no work with Lambert-Eaton myasthenic syndrome. So those are my references, and I reached the end of my presentation. Thank you for listening.
Can you clear your screen, please? Where are you? I can't see your face. Okay. Any comments to the group about this presentation?
I really enjoyed the videos of the physical exam. That was a nice addition to your presentation. So thank you for that.
Yeah, and I never thought that myasthenia gravis patients, they presented that way. We always see the textbook definition of what it could be, but I've actually never seen how somebody would present it. It's interesting.
And also other important differential diagnosis that should be mentioned is botulism, because it's also presented with a descending problem, just like myasthenia gravis.
I thought that was a very, very excellent presentation. I think you did a lot of research, really covered all the treatments you're talking about rather than reading was very helpful. Made you look more like an expert. Your graphics were wonderful. It was an excellent presentation. Okay, really.
Thank you.
I learned a lot. I always, I'm an old guy. I learned a lot from all of you, your presentations. Always something I learned that I didn't know. We had a man come into the office. He told him breathing, and he really couldn't breathe very well. I guess he was in a myasthenic crisis. I never seen one. I know about the eyes, but I never seen when we're breathing was very difficult. So as you were saying, it can take over the whole body. The other thing about swallowing, that's pretty critical. And I would imagine that he may be getting a lot of food down the wrong pipe, and choking. When a patient comes to the emergency room for a stroke, almost the first thing they do is come with a cookie and a glass of water to make sure they can swallow. It's a complicated reflex, and yeah, I can see that being very difficult. The only therapy is speech therapy, which is speech therapy is much more than speech therapy. Very comprehensive treatment of the the whole speaking and talking apparatus, muscles and articulation and so forth. But there is swallow therapy. Small bits of food, water, eating very slowly in small amounts. But that reflux doesn't work too well. It's muscular, the muscles are tired. You know, it was a wonderful presentation. The next presentation is, okay, he leaves the office and then what? Like this guy we just saw. I'm not picking on you. I'm saying that there needs to be there's a program called with medical coaches, medical coaching. And that when he leaves your office, what does he do for the next week? You know? And if somebody can contact him and sort of coach him through the next few weeks, or be a regular coach, it can really help the doctor's treatment plan work. I know you're not coming to America, but in America, if he had myasthenia gravis and you discharge him, he would have, if he came back within 30 days, there would be a fine on the hospital. Again, which is, makes you look carefully at discharge plan. You probably should be able to call anybody or call you, but you're very busy. It's a general issue I have, is that helping people carry out the treatment plans is really difficult. Half the patients don't take the medications the doctor recommend, maybe for good reason. I don't know. The video on Lennox Gastaut, same thing. Patient comes in the office and you have a sense of what their life is like. I mean, it's horrible, obviously. And I guess it's important in some way to recognize that. And usually, I think we often try to tell mom boy what a great job they're doing. It's important that somebody else say, boy, it's a hard job and you're doing a great job. Now you think of a disease, very, very rare, and 3 or 4 parents get together and say, let's form a foundation. Okay. They look around the world to get people to help them. Now, the neurologist, Orrin Devinsky, is fantastic. Okay. He is the doctor who first used marijuana for Dravet syndrome. I don't know. And the family had to move out of state to get the stuff. Huh? Fantastic neurologist. Maybe I could say you some things about him, but he really, started the marijuana for certain symptoms, syndromes. So his name is great, and what he does is great. I'm glad he was on. He's coming on that tape. I knew it was a good tape because he's the best in the world.
Hello, Dr. Stein. I have a presentation. Can I present?
Sure. Hang on. Let me get you co-host. Okay. Wait a second. You are a co-host. Okay. Can you bring up your screen? Bring your screen a little bit more down so we can see your face. Okay. I don't see your screen yet. I start seeing your screen now.
Is this slide visible, Dr. Stein?
It says double click to enter full screen mode. Is that okay? What I see here is you have brought up your screen. Oh, okay, that's getting better. Look, it takes 15 to 20 minutes sometimes to do this, so don't worry about it. It's hard to do.
Can I start, Dr. Stein?
Yeah, but you don't have this, your screen is not up. You can't see your screen. All I see is your file. Okay, now that's better. Let's see if we can get your picture here. View, standard, view.
Can you see it now?
I can see you. I cannot see you. For a second, you had your picture. The slide was perfect, and then it went away.
1 minute.
Nope. Nope.